It's perfect.
Okay.
Just make it big. Yeah, that's good.
May you start now?
Yes, you can start.
Okay. First of all, thank you for all certificates by this course. We are liking so much. My name is Carlos Demarque, and this presentation was do with my colleague Camila. We are pediatric cardiologists here in Brazil, in São José do Rio Preto. This is just to show you where is São José do Rio Preto in Brazil, state of São Paulo. I have a picture of our city. It's a beautiful city. Perhaps I like this. And this is our where we work. In the back, the children's hospital. Okay. In front, the hospital de base. It's a general hospital for adults. And at bedside, the School of Medicine and Nurse. Okay. Well, I just start like an introduction to show you a case that we had this this year. A pregnant woman, 32 years old, came for our institution for a fetal echocardiogram. Why? This is the second pregnancy. The first pregnancy is a girl with 2 years, 6 months, that has pulmonary atresia with ventricular septal defect. And the morphological ultrasound had difficulty in evaluating the outflow tracts in this pregnancy. I just show some fetal, some images of this fetal. The 4-chamber view is normal. Okay, you can see the right atrium, the left atrium, the right ventricle, and the left ventricle. This moving in the left atrium is the flap of the foramen ovalis. Okay, it's a normal 4-chamber view. This is the aortic arch, a normal, good size. But when you look for the outflow tracts, we see that from right ventricle and left ventricle, there's a VSD. And above this VSD, we just see a common outlet, a common valve, a single valve, a common artery. And this artery gives rise anterior to the aorta and posterior to the pulmonary artery. Another view of the same fetal in other position now, but this is the common trunk, the common valve arising the aorta, a good size of the aorta, and the pulmonary branches. In this case, we can see the pulmonary trunk. You see in the next slide the classification of the pulmonary trunk. Now here we see the right pulmonary artery and the left. In the side, at this side, you see in the upper the right pulmonary artery and the left pulmonary artery. Then the prevalence. Persistent truncus arteriosus occurs in fewer than 1% of all congenital heart disease. It's a rare congenital heart disease. The pathology. There's only a single arterial trunk with a truncal valve leaves the heart and gives rise to the pulmonary, systemic, and the coronary circulation. Like you can see in this pathology image, you see the right ventricle, the VSD, left ventricle, and a single common arterial trunk with a single valve. The coronary arteries, you can see here the right coronary orifice, and this common trunk. Oh, sorry. This common trunk gives rise to the aorta, and to the left and to the posterior of this trunk, the pulmonary artery. There's a trunk, a pulmonary trunk, and right and left arteries more. A large perimembranous infundibular VSD is present, dilating below to the truncus. We say that the truncus it's this communication, this ventricular septal defect. The truncal valve may be bicuspid, tricuspid, or quadricuspid, and it's often incompetent. Sometimes it has stenosis too. Another picture, pathology, okay. We can see in this image, the right ventricle wall was removed, and you can see the tricuspid valve, the arrow pointing to the VSD, and just a common trunk arises for this heart, and the other arrow to the left coronary orifice, the aorta, and the pulmonary artery, okay? In this one, you can see the pulmonary trunk was open. Okay, you can see the leafs of the valve, orifice of the left coronary artery, and like our case, we have no trunk, no pulmonary trunk. We have the right and the left pulmonary arteries arising near but separated. Okay. The pathophysiology. For physicians, this is important. Mixing of systemic and pulmonary venous blood in the ventricle. Então, systemic venous blood, low saturation, mixing with the pulmonary systemic return with high concentration of PO2 and mixing in the ventricle flow tract in the common pulmonary trunks. Then the oxygen saturation of blood in both great arteries and the aorta and the pulmonary artery is similar. The pressure in the ventricles right and left are identical, are similar too, because in general it's a large VSD. The level of oxygen saturation in the systemic circulation is proportional to the magnitude of the pulmonary blood flow. Okay, the better saturation, systemic saturation, when you have a high pulmonary blood flow. The magnitude of the pulmonary blood flow is determined by the level of the pulmonary vascular resistance. It's high in the when in the newborn period with a high vascular resistance. We don't have, like in the VSD that you see this morning, we don't have a pulmonary, the flow for the lungs are not increased. Then when the pulmonary vascular resistance decrease with 1-2 weeks old, the lungs started to receive more blood and the congestive heart failure started. And the other factor is the caliber, the diameter, the size of the pulmonary arteries, okay? In general, the type 1, like you see, is we have the enlarged pulmonary blood flow. Here, the classification. We have the first classification in 1949, the classification of Coolidge and Edwards in 4 types. Okay, in type 1, we had a pulmonary trunk and right pulmonary artery and left pulmonary artery. Type 2 and type 3, we don't have a pulmonary trunk. Okay, we have the right and left origin separated. In type 2, near, and in type 3, far one from another. Truncus type 4 is not a true persistent truncus arteriosus. Nowadays, it's classified like a severe form of tetralogy of low with pulmonary atresia. There's no real pulmonary artery, just collateral systemic pulmonary collaterals. And the pulmonary blood flow is increased in type 1, okay? In type 2 and type 3, nearly normal, okay? And the pulmonary blood flow is decreased in the type 4. Van Pra create another classification in 1965. There's 2 types, type A with VSD and type B without VSD. Truncus without VSD is rare condition, okay? Then you just talk about the type A. And then the type A1 is the same as type 1 by Cullet and Edwards. Type 2, type A2 corresponds to types 2 and 3 from Cullet and Edwards. Type 3 reflects the absence of the origin of one of the pulmonary artery from the common trunk. One artery it can be the right or the left, and this is representing the right pulmonary artery arising from the trunk, common trunk, and the left pulmonary artery arising from collateral, okay, other local. And the type A4 is truncles associated with interrupted aortic arch. Okay, in general, this interruption of aortic arch is type B, between the left subclavian artery and the left common carotid artery. Other classification we can about the dominance. When you have a small aorta and in general interrupted aortic arch, we have pulmonary dominance. Pulmonary blood flow is increased and systemic blood flow is decreased. This is more frequent. We have aortic dominance. The aorta is of a good size and the pulmonary arteries may be normal or to decreased size. Associated defects. It's common coronary artery abnormalities, stenotic coronary osseous, high and low takeoff of the coronary arteries, abnormal branches and course of the coronary arteries. Then we have this, give this information to the surgeon. Aortic arch anomalies, right aortic arch in 30%, interrupted aortic arch in 13%, and DiGeorge syndrome. Okay, almost 33% of patients had DiGeorge syndrome that is associated with hypocalcemia, thymus deficiency, immunodeficiency. Okay. Clinical manifestations. Cyanosis, like you see before, is the common. The saturation is lower than 95%, but the grade of oxygen saturation, systemic oxygen saturation, depends on the pulmonary blood flow, like I said before. Signs of congestive heart failure, and dyspnea with feeding, tachycardia, hepatomegaly, signs of respiratory distress are common when the pulmonary blood flow increased. Physical examination, cyanosis, signs of congestive heart failure, auscultation. A single S2, just as there's a single valve, then it's a single S2. And the murmur is because the dysfunction of the truncal valve. Okay, if you heard the systolic murmur, there's a stenotic truncal valve, and if you had a diastolic murmur, you have a regurgitation of the truncal valve. You can have the two, systolic and diastolic, when you have stenosis and regurgitation in the same valve. Electrocardiography. The QRS axis is normal. This is the characteristic of the truncles. Biventricular hypertrophy. Okay, both ventricles, right and left, show hypertrophy, present in 70% of cases. Isolated right ventricular hypertrophy or left ventricular hypertrophy is less common. Left atrial hypertrophy is occasionally present. Then this ICG, all the exams that I show is from our case of this fetal. Okay, this ECG was taken when he's a boy. In this occasion, it has 2 months old. We can see a sinus rhythm. Okay, the P wave is positive in the 2, 1, and AVF, and we see predominantly left ventricular hypertrophy, high R waves in the left precordial leads. Radiography. Cardiomegaly is usually present. Increase the pulmonary vascularity, right aortic arc in 30%. This is the X-ray of our baby. Here, with 1 day, you can see 1 day the pulmonary vascular resistance is too high, and the blood flow seems normal. And I can see the thymus, okay, and the cardiac is just it seems like the left ventricle is quite enlarged. But 2 months old, the heart is biggest, it's large, and the pulmonary blood flow increases. Okay, and then he was operated. Echocardiography. Echocardiography is a good exam, no radiation, and is give the diagnosis, the repercussion, the hemodynamics, and orientation, the treatment. We can see the VSD, the size, the location. We can see a single great artery arise from the heart. You can identify the pulmonary artery anatomy and size, and then the truncal type. We evaluate the truncal valve, number of sinus and function, stenosis or regurgitation. We study the coronary artery anatomy and the aortic arc. You can see to the left or to the right, and if there is interruption or no. This video is from the baby. On the first or second day of life, okay, it's similar to this fetal image. Right ventricle, left ventricle, the VSD, just one great artery, okay, a common arterial trunk, one valve. It's a good valve. This baby has a good truncal valve, no dysfunction. Anterior arise the aorta and posterior into the left. I can see here the left pulmonary artery without flow, mapping the color flow in this with color flow. Another picture just with a zoom of the outlet. There's a common arterial trunk. Okay, just to see better the two arteries in the color, we can see better. This is the left one, and this is the origin of the right one. Okay, there is no trunk, then we classify this trunk as like type 2. Natural history. Most infants with congenital heart failure during the first 2 weeks, okay, after reduce the vascular resistance. A total of 85% of untreated children die by 1 year of age. Clinical improvement occurs if the infant develops pulmonary vascular obstructive disease, which may begin to occur by 3 to 4 months of age. Then you have to follow up these new babies and operate it as soon as possible, because they can develop the Eisenmenger or pulmonary vascular disease, is better to say, early in life. Death occurs around the 3rd decade if for that don't treated in the newborn period and evolution with pulmonary vascular disease. Truncal valve insufficiency worsens with time. Management, medical, we have a few things to do. Clinical treatment for heart failure, diuretics and ACE inhibitors may be used before operation. Because of the frequent association with the DiGeorge syndrome, we have to take care of the serum calcium and magnesium levels, and supplementation may be indicated. Only irradiated blood product should be used for an urgent surgery because of an insufficient time to evaluation of immune status accurately. Because of the thymus-based immune deficiency, treatment and prophylaxis against pneumococcal and streptococcal infections are important. We can't forget this. Surgical repair. Ideally, surgery should be undertaken within the first week of life. When the diagnosis is delayed, surgery should be performed on an urgent basis after 2 or 3 days of medical stabilization. Palliative procedures was performed in the past. This procedure is associated with a high mortality rate as high as 30%, and it's not performed nowadays. Just to illustrate how can the surgeon and reconstruction these hearts. For truncus type 1, the traditional is the Rastelli operation, and it's necessary to open the right ventricle, okay, separate the pulmonary artery from the common trunk, close the VSD, and use a conduit to connect the right ventricle to the pulmonary arteries. This conduit will not grow with the child, and in the future it will be necessary to change. Barbeiro Marcel is a technique that open the pulmonary trunk and the right ventricular flow thread like in tetralogy of follow. Close the origin of the pulmonary artery from the trunk, common trunk, close the VSD, and use a patch to like a roof to cover this region. Okay. There is no valve and pulmonary regurgitation, free pulmonary regurgitation in this case. Surgery for truncus type 2 or 3 is quite complicated, more complicated because more aortic tissue will be removed and the aortic, ascending aorta will be reconstructed. Post-operative, this is the echo of our patients, okay? He was performed a Rastelli procedure. You can see the left ventricle. Now the new aorta valve, with good function, and the aorta without the pulmonary arteries was removed from this position. And the other view, it's the right ventricle view. In the subcostal view, you can see the right atrial tricuspid valve, the right ventricle, and the conduit connecting the right ventricle to the pulmonary artery with a good flow, with a good function of both ventricles. And then the last follow-up, this child have to follow up every 4 to 12 months. Progressive truncal valve insufficiency may develop, and truncal valve repair or replacement may be needed. Calcification of the valve in the conduit may occur within 1 to 5 years, which requires reoperation. Ventricular arrhythmias may develop because of right ventriculotomy. We can't forget prophylaxis of bacterial endocarditis. And about sports, the patient should not participate in external competitive sports. Okay, thank you. I want to thank you to Children's Heart Link, that is an institution that is supporting us here in São José do Rio Preto for several years. This is our team, physician team, okay, predominantly women. I am here, sit down. This is Camila, that helped me in this presentation. This is the surgeon, Dr. Ulisses, and Dr. Fernando is surgeon too. Thank you for your attention.
Thank you. Does anyone have any questions? Okay, thank you so much. I've actually been to Ribeirão Preto in Brazil a long, long time ago, and it was an amazing place. So thank you for sharing this presentation. I like how you started out with the case of the 32-year-old, and also that you showed the truncus and the different classifications of truncus, and also used different formats to do it. So echoes and echoes and the pathology specimen as well. Also differentiating that the fourth type of a truncus is not really a fourth type, it's tetralogy of Fallot with pulmonary atresia. And coming up in a few weeks is Audrey Zolan, who's a physician who's going to be talking about tetralogy of Fallot and pulmonary atresia. So anyway, lots and lots of good information about the surgical repair, and looking at the pre and post echo was also very interesting. So thank you. So we have one more presentation. Let me just stop the recording.